Welcome everyone. Today we're presenting an educational session on the scope of practice for APRNs, comparing Texas and Oregon. This presentation was put together by our group: Abigail Helton, Aminu Mahamud, Candace Jeffers, Emma Gorel, Josephine Feniku, Melinda Rowland, Natalie Mahamud, and Sarah Martin. We'll be diving into the differences and unique regulations each state has for APRNs with a specific focus on psychiatric mental health practice. Let's get started. To understand the scope of practice for APRNs in Texas and Oregon, it's essential to look at each state's Nurse Practice Act. These acts establish the regulations that guide nurse practitioners' roles, responsibilities, and limitations within each state. On this slide, we've included links to the Nurse Practice Acts for Texas and Oregon so you can explore them in detail. Each state emblem represents the unique guidelines that define APRN practice in these regions. These acts are the foundation of our discussion, helping us understand how APRN scope of practice varies from state to state. In Texas, the term Advanced Practice Registered Nurse is used broadly. It includes not only nurse practitioners, but also nurse midwives, anesthetists, and clinical nurse specialists. Texas emphasizes completion of an advanced educational program with licensure as a central requirement. This shows a structured, regulated approach, recognizing nurse practitioners within a larger umbrella of advanced roles. In contrast, Oregon defines a nurse practitioner with an emphasis on independence. Oregon's Nurse Practice Act allows nurse practitioners to assume full responsibility and accountability for patient care independently, as long as they're licensed. This wording highlights Oregon's support for autonomy within the role. These definitions reveal a key difference. Texas sees nurse practitioners as part of a collaborative physician-supervised model, while Oregon supports a more independent practice model. This contrast reflects each state's varying approach to consensus model for APRNs. In Texas, APRNs have several recognized roles within specific scopes of practice. The Texas Board of Nursing recognizes 4 primary roles. Nurse practitioners provide primary and specialty care, diagnosing and managing various health conditions. Clinical nurse specialists focus on improving patient outcomes through expertise in a specialized area of healthcare. Certified nurse midwives provide reproductive health care, including prenatal and postpartum care. Certified registered nurse anesthetists, also known as CRNAs, specialize in administering anesthesia and managing anesthetic care. Each of these roles has a unique function, allowing APRNs to meet diverse patient needs within their specialized scopes. Oregon takes a similar approach but recognizes 3 key APRN roles. The Oregon Board of Nursing designates nurse practitioners who assume independent responsibility for comprehensive patient care from diagnosis to treatment. Clinical nurse specialists work within specialized fields to enhance care quality and support clinical practices. And certified registered nurse anesthetists administer anesthesia and oversee anesthetic care for surgical and procedural patients. Oregon's streamlined set of APRN roles emphasizes broad, independent practice, reflecting the state's support for APRN autonomy. In Texas, APRNs operate under a restricted practice authority. This means they need a supervisory or collaborative agreement with a physician to diagnose, treat, and prescribe. Prescriptive authority is also limited, requiring supervision and carrying specific restrictions on controlled substances. Texas recognizes APRN roles including nurse practitioners, clinical nurse specialists, certified nurse midwives, and CRNAs, each with their own defined scopes. The regulatory emphasis here is on collaborative practice with physicians, aimed especially at supporting patient care in rural and underserved areas. Overall, Texas's model highlights a structured approach with physician oversight, which contrasts with more autonomous states like Oregon. In Oregon, APRNs have full practice authority, allowing them to evaluate, diagnose, and manage patient treatment independently. they also have prescriptive authority without the need for physician oversight, including the ability to prescribe controlled substances. Oregon recognizes nurse practitioners, clinical nurse specialists, and CRNAs, each role clearly defined under the Oregon administrative rules with specific standards and competencies. The state's regulatory emphasis supports APRN autonomy, prioritizing independent practice to enhance patient care. This structure highlights Oregon's commitment to APRN independence, providing a contrast to Texas's more restrictive model. This table gives a quick side-by-side comparison of the APRN scope of practice between Oregon and Texas, highlighting key areas. For practice authority, Oregon offers full independence, while Texas requires APRNs to operate under a restricted authority with a supervising physician. In terms of prescriptive authority, Oregon APRNs have full prescriptive power, including controlled substances, while Texas limits this with additional supervision and restrictions. APRN roles are similar, with both states recognizing nurse practitioners, clinical nurse specialists, and CRNAs. Texas adds certified nurse midwives to its list, slightly broadening its role recognition. Finally, the regulatory emphasis reflects each state's philosophy. Oregon emphasizes APRN autonomy, while Texas focuses on collaboration, particularly to support rural areas. This table lets us see at a glance how each state balances APRN independence with collaborative care requirements. Oregon leans towards self-governed practice, while Texas integrates APRNs within a more structured, team-based model. In both Texas and Oregon, PMHNPs can treat patients across the lifespan, from children to older adults, based on their specialty. Texas requires alignment with specific population focus areas, while Oregon allows PMHNPs full independence to care for all age groups as needed. This slide outlines some of the certifications and orders that nurse practitioners in Texas and Oregon are authorized to perform, emphasizing their role in patient management. For disability certifications at the state level, Texas allows it, but it's form dependent, while Oregon provides a straightforward yes. For federal disability certifications, both states permit them, though each is form dependent. Handicap parking permits are authorized for nurse practitioners in both states. When it comes to certifying homebound status for school children, Oregon allows this, but Texas does not. Both states permit nurse practitioners to order medical equipment and authorize physical therapy for patients. This table highlights that while both Texas and Oregon enable nurse practitioners to perform a variety of certifications and orders, Texas has a few more restrictions, particularly around specific forms and school-related certifications. Telepsychiatry has become a popular option for expanding mental health access across the U.S. On this slide, we're looking at how Oregon and Texas approach these services differently. In Oregon, telehealth practices are quite flexible, allowing practitioners more independence as long as they meet licensure and confidentiality standards. Texas, however, requires psychiatric mental health nurse practitioners to establish a valid relationship with a collaborating physician before providing telepsychiatry. This reflects Texas's requirement for nurse practitioners to work under physician supervision. So both states allow telepsychiatry, but Oregon offers more independence for practitioners compared to Texas. On this slide, we're looking at the role of PMHNPs in both Texas and Oregon regarding psychiatric evaluations and assessments. In both states, PMHNPs are authorized to conduct psychiatric evaluations and certify assessments. This ensures that they can deliver comprehensive care independently within their scope of practice. Allowing PMHNPs to perform these key functions highlights the importance of their role in mental health care, providing patients with timely and effective evaluations across state lines. In both Texas and Oregon, psychiatric mental health nurse practitioners have the authority to initiate emergency holds if a patient is assessed as a danger to themselves or to others. In Texas, PMHNPs can initiate these holds independently after a proper assessment, taking immediate action to protect patient safety. In Oregon, PMHNPs have similar authority but often need to collaborate with law enforcement after conducting an emergency assessment. This adds a layer of procedural coordination that reflects Oregon's approach to involving other services in emergency situations. While both states share a commitment to patient and public safety, the difference lies in how each state incorporates collaborative support, particularly in Oregon's additional requirement for law enforcement involvement. Involuntary commitment procedures do not have a big variance between both states. In Texas, involuntary commitment requires a court order based on an affidavit showing that a person is an immediate danger to themselves or to others. The initial commitment can last up to 90 days, with the option for extensions. Judges can consider concerns from various parties during the decision-making process. Oregon's approach is structured for extended treatment in cases of ongoing risk. The commitment period can last up to 180 days and requires a court hearing with judicial review. Similar to Texas, Oregon allows judges to consider documentation from any concerned party. So, to wrap it up, Texas and Oregon both focus on patient and public safety, but Texas's shorter hold duration and affidavit-based process contrasts with Oregon's extended timeline and formal judicial review, reflecting their distinct legal frameworks. In Texas, the nurse practitioner licensing process involves several key steps. First, candidates must complete an approved graduate program specific to their chosen APRN role. Next, they must pass a national certification exam in their specialty, such as family or psychiatric mental health, which verifies their competence. Once certified, the candidate applies to the Texas Board of Nursing for APRN licensure. This application requires proof of education, certification, and compliance with state-specific requirements, including criminal background checks. Lastly, Texas requires APRNs to establish a collaborative agreement with a supervising physician for practice. This adds a layer of regulated oversight unique to Texas's licensure model, differentiating it from states with independent practice. In Oregon, the nurse practitioner licensing process is designed to support autonomy in practice. First, candidates must complete an approved graduate program tailored to their specialty area, just like in Texas. They also need to pass a national certification exam for their chosen specialty to confirm their qualifications. After certification, candidates apply to the Oregon Board of Nursing for licensure. This application includes providing proof of education, certification, and a background check, similar to the Texas process. However, unlike Texas, Oregon does not require a collaborative agreement with a physician, granting APRNs full practice authority. This allows nurse practitioners to operate independently, reflecting Oregon's emphasis on APRN autonomy. In this slide, we're comparing the prescriptive authority of nurse practitioners in Texas and Oregon, which reflects each state's approach to APRN autonomy. In Texas, nurse practitioners have restricted prescriptive authority. This means that APRNs must have a supervising physician to prescribe medications, especially for controlled substances. They face additional supervision and limitations on certain types of medications, reinforcing Texas's collaborative model. In Oregon, where nurse practitioners enjoy full prescriptive authority, they can independently prescribe medications, including controlled substances, without physician oversight. This autonomy aligns with Oregon's emphasis on APRN independence and self-regulated practice. On this slide, we'll discuss the role of PMHNPs in ordering imaging studies, coordinating special procedures, and providing psychotherapy. PMHNPs may order imaging, such as MRIs or CT scans, to rule out neurological conditions when symptoms suggest a neurobiological cause, like brain abnormalities or strokes. While PMHNPs don't administer ECT, they can refer patients, assess if they are good candidates, and participate in post-treatment care. In Texas, PMHNPs can prescribe Suboxone for opioid use disorder if they're trained and credentialed, following the Texas Administrative Code. PMHNPs can refer patients for TMS, commonly used for treatment-resistant depression, although it's performed by other trained professionals. PMHNPs may offer or refer patients for psychotherapy. Modalities include CBT, DBT, psychodynamic therapy, and trauma-focused therapies like EMDR or prolonged exposure therapy. These roles underscore the broad and versatile scope of PMHNPs in managing complex mental health needs through various therapeutic approaches and specialized referrals. In this slide, we're comparing the authority and requirements for nurse practitioners in Texas and Oregon when it comes to ordering controlled substances. Texas has strict constraints. NPs must follow practice agreement parameters, also known as PAA, and their prescriptions often have specific duration limits. In Oregon, NPs have full prescriptive authority for controlled substances. They need a certificate of prescriptive authority from the Oregon State Board of Nursing and must be enrolled in the Prescription Drug Monitoring Program for oversight. This shows the difference in regulatory approaches, with Texas imposing more restrictions and Oregon allowing more autonomy for their NPs. Here's an overview for both states of what goes into applying for a DEA registration as an NP. To apply, you'll need your Social Security number, home and business addresses, contact details, license number, OSBN prescriptive authority for Oregon, and your NPI number. The application is completed online by submitting DEA Form 224. There's also a fee of $888. Once approved, you'll receive a DEA registration certificate and a unique DEA number, which must be on all controlled substance prescriptions. Registration is typically valid for 3 years before it needs to be renewed. Here is an overview of the certification, training, and collaboration requirements for NPs treating opioids.